who heads up the primary care team at the Alliance. We've got myself, I'm Louise Roberts. I'm the Senior Quality Improvement Manager at the Alliance. And we've also got Dr. Debbie Harvey, who, amongst many other roles, is the Cheshire Merseyside and CLUK GP lead. So, without further ado, let's get the webinar started, and I'll introduce you to our first speaker, Dr. Chris Warburton, the Medical Director at Cheshire Merseyside Cancer Alliance.
Thanks, Louise. I'm just checking you can all hear me. Somebody say yes.
Yes.
Thank you. I wasn't clear. I had my headphones plugged in, and when you take them out, sometimes it doesn't happen. So, for those who don't know me, my name's Chris Warburton. I'm a respiratory physician at Liverpool Hospitals. I'm the Medical Director of the Cancer Alliance. Next slide, please. So my role today is to sort of take you through fairly quickly just what the Cancer Alliance is. What on earth is a Cancer Alliance? I hear you asking, what do you do? Well, I guess we are an NHS England body. We are tasked with doing things around cancer for a population. The population in question, of course, for this one is Cheshire Merseyside. I'm going to talk to you about what we do, our governance, how we do things, what sort of rough areas of work that we're involved with. So I'm not going to go through the detail of that. That's what the second half of the webinar is about. Really what we managed to do in terms of COVID and the effect on cancer, and then what's going to happen in the future. Next slide, please. So you should all know what this is. This is essentially us. This is Cheshire Merseyside. We've got 9 places, 14 trusts providing cancer services, lots of PCNs, so 50 PCNs, lots of GP practices, and 2.6 million residents, which is obviously the most important factor in that. Next slide, please. So what do we do? Well, we bring together organisations to try and affect how cancer is delivered, and that ranges from early diagnosis right through to end of treatment and on to terminal care. We work closely with all those people to provide better services, better cancer care in terms of that. But I guess for me, what we're mainly about is around improving cancer outcomes. So that's around early detection, early diagnosis where we can, getting people into systems quickly, getting their treatment quickly, and ensuring that they get the right sort of treatment in terms of their patient experience. Next slide, please. Next one, thanks. Thank you. So we know in terms of cancer in Cheshire Merseyside, we have a lot of cancer in Cheshire Merseyside. We have more cancer proportionately than many other areas of England, particularly. We know we have 7,000 deaths due to cancer each year. We have lots and lots of people, 100,000 people living with cancer, so who've been through treatment, who may still have the disease or have effectively had cure. And we know that we diagnose a lot of them of new cases each year, 16,000. And no surprises as to where the common cancers are. They're the ones that are common nationally, so colorectal, prostate, lung and breast, and then a big group of other cancers that are lumped in together. Next slide, please. So the way that we effect change within Cheshire Merseyside is to collaborate with our other colleagues within the NHS, particularly yourselves in primary care, partners in the third sector, trusts who deliver the cancer services, etc. We try to bring together the experts in cancer care to deliver our positive change and how cancer is delivered, cancer services are delivered. We do have some responsibility, so we have responsibility for performance, quality and other outcomes across the Cheshire Merseyside footprint. Next slide, please. Our governance framework is that we are funded by NHS England, and we're accountable to a variety of different bosses, if you like. The National Cancer Programme, so there's a National Cancer Team, so we are accountable to the National Cancer Team with regards to our programmes, but also regionally to NHS England for our key objectives. And I think there are 3 big areas that we're involved with, which are just 2 of which are listed on that slide. The first is delivering NHS long-term plan ambitions for cancer. If you look at the long-term plan ambitions for cancer, it's relatively simple in the fact that the NHS England would like us to deliver early diagnosis, so getting cancer diagnosed at stage 1 or 2 in 75% of patients. And that translates into an increased number of people surviving cancer for longer. The second one there is that we are accountable for delivering the constitutional waiting time standards. That's not necessarily represent an issue for primary care networks. That's more around our acute trusts who receive your referrals. And then there's a third group, which is not on there, but it's about the other things that we do around cancer that aren't directly in the NHS long-term plan. So there are lots of things that we're involved with, which we'll show you this afternoon, that we're doing that aren't written down in the NHS long-term plan in as many words, but they're implied. So it's about improving cancer processes, if you like. But there's a big group of things that we're doing underneath those subheadings that deliver the better services and better experience for patients. Next slide, please. So from a medical perspective, I'll just start by speaking medically. We have a number of groups who are relatively tumour specific, along with some cross-cutting groups. So you'll see them listed in the second paragraph there. So we have a number of tumour specific groups: breast cancer, colorectal cancer, etc. We've got some cross-cutting groups, which includes primary care or general practice clinical quality groups, psychology, genomics, etc. And along the bottom there is a list of what we sort of expect our clinical quality groups to consider for their sphere of influence, for their expertise, if you like. So, for instance, the brain and CNS CQG would be looking at all those things and trying to work out how they can influence across Cheshire Merseyside those things to improve the lot of patients with cancer across Cheshire Merseyside with their particular cancer. They feed into the Cancer Alliance board. Our senior responsible officer for cancer is Dr. Liz Bishop, who's the chief executive at the Clatterbridge Cancer Centre, and I'm the medical director of that group, obviously. But we have a cancer board, a cancer programme board, and the CQGs feed into that. Next slide, please. In terms of our programmes of work, there's a longish list there, ranging from earlier diagnosis of cancer through to genomics workforce, etc. And we're going to talk to you just very briefly this afternoon, I think, about most of the things on there. Next slide, please. So in terms of giving a little bit more detail about some of these things and how we've managed the impact of COVID, in terms of early diagnosis and prevention, I'm sure Debbie's going to talk to you more about what we've been doing with CR UK, PCNs, the DARES and QOF, etc. This is one of a number of webinars I know that have been happening around this. In terms of early diagnosis, and particularly with respect to the endoscopy issues that we've got across Cheshire Merseyside and nationally at the moment, we've implemented FIT, or fecal immunochemical testing, for high-risk symptomatic patients in secondary care, and also FIT in primary care for low-risk patients, to try and manage those endoscopy waiting lists and try and reduce those where we can. Despite COVID, I think we've implemented the targeted lung health check programme across Knowsley, Halton and Liverpool. We are very hopeful that we'll get some additional CCG areas into that programme very soon. And we supported as much as we can the recovery of cancer screening programmes, which were all paused due to COVID, but have come back online and are now diagnosing screen detected cancers again. In terms of diagnosis, and this is an important area, we've accelerate the implementation of rapid diagnostic centres. So rapid diagnostic centres, under another name, is essentially looking at cancer pathways and trying to improve the cancer pathways, make them more streamlined, efficient, etc. And we're doing that across a number of both non-specific symptom RDCs, but also some of the site-specific ones as well. We've been developing optimal pathways to make sure that people referred on a pathway, for instance, for gynae cancer, get the same investigations at the same time, independent of where they're referred within Cheshire Merseyside. And in terms of treatment, we set up some pilots around prehabilitation to try and improve outcomes from cancer, personalised follow-up to try and reduce the number of people waiting to see consultants in clinics and having different ways of following people up. And then lots of stuff around workforce. We, as you know, as you well know in primary care, there are deficiencies in workforce across the NHS. I think that's clear in all cancer services that I can think of, and what we've been trying to do is to try and identify the most pertinent ones for the cancer workforce, try to put some work into those areas to try and improve the number of people on these in these jobs, to try and improve the efficiency of our systems. One thing we did do was to implement a surgical hub around COVID, so that meant that we were trying to use mutual aid between organisations to move patients, if we had to, across Cheshire Merseyside for their treatment, surgical treatment for cancer. And we've been relatively successful in that. Generally speaking, people did move during the COVID waves. I think we've settled back into people being managed more locally now, but certainly during the COVID peaks of the waves, we were moving people around Cheshire Merseyside for their surgical cancer treatment. Next slide, please. So our challenge going forwards is really to ensure that we've got sufficient both diagnostic and treatment capacity for what's coming around the corner. I think it's fair to say that the number of referrals into cancer services has increased from pre-COVID levels, and I think what we're seeing now is we've probably done the catch-up part in the main. You know, we've probably referred on those patients who were paused due to COVID and didn't present. I think we're now looking at a real-time increase in the number of people presenting with suspicious cancer symptoms, because it grows year on year, and we know it grows year on year. And so I think what we're seeing now is so apologies for that issue coming forwards. I think we are continuing to encourage people with symptoms to come forwards, and I would encourage you all to refer patients who you feel have suspicious symptoms onto cancer pathways, irrespective of how those cancer pathways look at the moment. You know, I think we need to get those people in the system and deal with that, and unless we know the number coming in, we can't really deal with, you know, the capacity that we need. So we need to ensure that capacity is in place to diagnose all those additional people at all points, really. Next slide, please. The bottom bullet point on that previous slide was just with regards to something called a 28-day standard. That's a new standard which is sort of going to replace the 2-week standard at some point, but it means that patients referred via that urgent GP route should be told they've got cancer or don't have cancer with some certainty within 28 days of referral. I think that's a very clear quality thing for patients, to get that reassurance that they either know or they don't know by day 28, and that stops people loitering on lists for a long time. So what are our plans going forward? Well, you can read these yourself, but in terms of early diagnosis and prevention, we're going to continue to work with yourselves as PCNs, delivering the requirements of the DES and the QOF, etc. Deliver the FIT and expand that program even further. Newer innovations, something called colon capsule endoscopy, so trying to reduce the number of people requiring conventional colonoscopy. We are expanding those targeted lung health checks into different populations. You may or may not be aware that South Sefton and St Helens have been awarded funding to become part of that targeted lung health check program. And for those of you who don't know what that is, that's essentially doing a lung health check with the patient, assessing their cancer risk, and if they meet a certain criteria, offering them a low-dose CT scan to try and pick up early lung cancers. And there's good evidence from a number of previous studies that actually, if we do this, we will diagnose patients with lung cancer at an early stage, which is good for them and good for their outcomes. We started something called the Grail, or the NHS Gallery study, which is evaluating a blood test looking for circulating cancer DNA. That started over in Runcorn and is going to spread around Cheshire Merseyside over the next 12 months. And we're working on prevention around tobacco control in a variety of settings, obesity, community engagement, etc. We're going to continue to support the cancer screening programs as well. We're going to continue also to work on our RDCs, but also we're involved as a Cancer Alliance in the introduction of community diagnostic hubs. So these are, as the name suggests, in the community, they're hubs for diagnosis, and obviously cancer diagnostics is a major part of that. With support of the elective recovery program, particularly around endoscopy. The endoscopy network was set up originally under the auspices of the Cancer Alliance, and we continue to be directly involved in the endoscopy work. We are going through some work around the Lynch syndrome testing process around genomics and the colorectal and gynae pathways. And then there's a number of things around treatment. As I've said, the RDCs for non-specific and site-specific symptoms. More optimal pathways, so getting other cancer pathways as an optimal pathway. Continuing to try and implement personalised follow-up and stratified follow-up for patients. And a major work programme around workforce. So again, I think we're all aware of the issues that workforce create for us. We're continuing the surgical hub for now, and I think as we will move in towards the ICS and the ICB, we will get more working together of provider organisations in their provider collaborations or collaboratives. So I think those surgical things, the surgical will continue and probably evolve into a surgical management or a surgical team, I guess, for Cheshire Merseyside, looking forwards into the future. Next slide, please. So that's a flavour of what we do and who we are. So I think we are a well-funded organisation. We have one major role, and that's cancer improvement work for Cheshire Merseyside services generally around cancer, ranging right from primary care and working with yourselves as PCNs and individual general practitioners. If you have things that you feel you would like us to get involved with, then certainly our ears are open. We'd be very happy to work with you. There's some key links and contacts. That's all from me. I'm very happy to take any questions. Otherwise, I'll hand over to the next speaker.
Thanks, Chris. That's myself, I think. I'm Jenny Hampson. I'm the Performance Information Analyst for Cheshire Merseyside Cancer Alliance, and I've just been asked to run through some data in relation to cancer in Cheshire and Merseyside to kind of paint the picture of where we stand as a footprint. So the first slide that I think we're going to come to is a bit of a summary of what we'll then look at in the following slides. One of the key things that we're aware of for Cheshire and Merseyside is that almost a quarter of our neighbourhoods are within the 10% most deprived in England. There is some disparity in terms of the local authorities or clinical commissioning groups, with some having much more deprived areas, some having fewer deprived areas. As an example, Cheshire CCG has around 5% of their neighbourhoods within the 10% most deprived, and Liverpool CCG has very nearly half. We're looking at nearly 300,000 people within those areas, and health deprivation, if we look at that as an individual aspect rather than deprivation as a whole, is actually higher for Cheshire and Merseyside than the average deprivation. We're looking at around 33% of the population in the top 10% for health. So Cheshire and Merseyside has around 16,000 new cancer cases a year, 7,000 deaths due to cancer. And incidence is around 5% higher than England, and cancer mortality is 8% higher. So we are more impacted, which makes sense when we've got high levels of deprivation, which is obviously a very strong correlation with health in many aspects. Knowsley CCG is one that we've noted as being the second highest cancer incidence in England, and cancer mortality in Knowsley, Liverpool and Halton is known to be 20% above England. Early stage diagnosis is similar to what we see in England as a whole. There's been little recent improvement. There is an ambition to reach 75% for England. Obviously, neither England nor ourselves are at that point at the moment. And on average, we worked out that if we were to achieve that ambition, we'd be looking at around 7 additional patients per GP practice being diagnosed at an early stage. Which isn't to say we expect you to do that, it's purely as an indicator of what we'd be looking at. Our 1-year survival rate has improved, so we were below the England average and we're now above the England average in terms of how many patients will survive 1 year following a cancer diagnosis. However, in terms of looking at the individual CCGs within the Cheshire Merseyside footprint, the range lowest to highest is widening. Screening coverage is similar to the England average with variation in the CCGs, and that again is linked to deprivation. And can we have the next slide, please? Which I think will look familiar because Chris had the same slide in his slide set, which was just to paint the picture of what we're looking at as Cheshire Merseyside as a whole. So obviously it's a large area. We've got 9 CCGs or 9 local authorities, depending on which way you look at it. And we're looking at around about 50 primary care networks. It's varying, I think, as things change, but that's still quite a lot that we're trying to work with. Could we have the next slide, please? So this comes back to the deprivation that I mentioned before. The graph at the bottom shows England at the top with the nice 10% most deprived, 10% second most deprived, and so on. Cheshire and Merseyside is shown underneath, and you can see that the first red block is much wider for Cheshire and Merseyside compared to England. And then if we look at the health domain, that again is wider for health, being at 33%. So this is just to highlight that we do maybe have some additional challenges compared to England as a whole. We recognise that, and what we're trying to do is work with those challenges and make sure that we're supporting people within those areas appropriately. Could we have the next slide, please? What this then shows is that variation that we see within Cheshire and Merseyside for deprivation. So within Liverpool, we're at 48.7% of neighbourhoods within the top 10% most deprived. And then we're looking at, as I said, Cheshire is 4.5%, but we also have variation between those two. So Knowsley and Holton, close to Liverpool, South Sefton starting to be a little less, but still high. Wirral, St Helens, and then we're looking at the bottom of the scale for Warrington, Southport and Cheshire. Although what we are aware of is that if you look at things on a local authority footprint or a CCG footprint, we do know that that can mask disparity within these clinical commissioning groups or local authorities, and that some, for example, Cheshire can have some very deprived areas within what is mostly an affluent community. So that's something that we're also making sure we're aware of when we're doing our work plans and working out where we need to be putting support. Could you have the next slide, please? Just for context, this is nationally published data and this is also available on our website. So as I mentioned before, 16,000 new diagnoses a year. We're looking at 12% of those being colorectal, 13% prostate, 15% lung and 15% breast. All of the other cancers account for the remaining 46%, excluding those non-melanoma skin cancers. We do get that data broken down within the Alliance to the cancer types, but for the purposes of publicly available data on the website, this is how it's grouped. We're looking at around about 100,000 people living with cancer in Cheshire and Merseyside, and as I said before, 7,000 deaths. So to put in context of how many people we are trying to support and help through the cancer pathways. Could you have the next slide, please? Thank you. So in terms of incidence, this is just comparing our incidence in Cheshire and Merseyside against England as a whole. I'm sure a lot of you are aware that cancer data tends to run about 18 months behind in terms of what we have available to us that's all been data quality checked. So we're looking now at 2016 to 18. And Cheshire and Merseyside had 640 per 100,000 compared to England being 611. So what we're looking at there is that, yes, we do have a higher incidence than England. And in the graph below, you can see the split out by the CCGs. Southport and Formby having the lowest incidence and Knowsley having the highest incidence. The orange line shows the Cheshire and Merseyside average and the blue line shows the England average. Next slide, please. This is the same information but for mortality rather than incidence. So again, we are higher than England. And we do have, again, that disparity that can be seen within the CCGs. In this case, we're looking at the old Cheshire CCGs before they amalgamated. So Eastern Cheshire was the lowest. But you'll notice that 3 of those 4 CCGs, Eastern Cheshire, South Cheshire and Vale Royal, were the 3 lowest ones in terms of mortality. West Cheshire sat about in the middle. Next slide, please. Thank you. So in terms of early stage diagnosis, I think Chris mentioned this, the ambition for 75% of cancers to be diagnosed at an early stage, with there being strong links between early diagnosis and better survival. So as I mentioned before, we're similar to the England average at 53%. Over the past 6 years, we've seen very little change, and we would need a sustained shift to achieve that 75% rate. However, that is the same for all of England, not just Cheshire and Merseyside. We're looking at variation between 56% in Liverpool and 53% in Southport and Formby when we look at it on a CCG footprint. And this does tie in very strongly with the new 28-day standard, which Chris mentioned. That is coming into force from October this year, so now. It was delayed due to COVID, so it was due to come in last year. And then because of pressures within the services, it was delayed. But we'll be monitoring that quite closely going forwards, as that obviously, as Chris said, improves the cancer pathways for patients, gives them an answer sooner so they're worried less, and also allows them to start treatment earlier on when they move on to that 62-day pathway. If we can shorten the front end of the pathway, hopefully we'll be shortening the whole pathway going forwards as a result of that. So I think early stage does tie in very clearly with these new targets that we've got. Can we have the next slide, please? So this one just breaks down early stage by tumor type, and I think there's no real surprises in terms of how the data is broken down. Breast is 85% at an early stage, which we know it's always in the media. Women are very forward at coming forwards. I think for breast cancer, much more so than maybe some of the other cancers. Then we look down to lung, which is one of the most common diagnoses. However, in terms of early diagnosis, we're looking at only 33%. And I think this is where things like the targeted lung health check program that Chris mentioned is really important, because with these cancers being diagnosed so late, the survival from lung cancer is so much worse compared to some of the other cancers that we are picking up at that early stage. So we can see that very clear correlation between late diagnosis and less survival. Tumours which are doing better than England but are still low in terms of early diagnosis percentage are stomach, esophagus, lung and non-Hodgkin's lymphoma. And tumours with the biggest gaps to the Best Cancer Alliance, so as in there are other cancer alliances that we measure ourselves against, they are maybe performing better than we are within some tumour groups, are kidney, ovarian and prostate. All of our cancer pathways are at least 12% below the Best Cancer Alliance within the UK. That isn't to say that we would expect to achieve the same as those cancer alliances, because those cancer alliances may have very different demographics making them up. We highlighted before that we have a higher proportion of people living in deprived areas than some other areas in England, but it is interesting to measure against, as it gives us a feel for where we sit nationally and what we would expect to achieve. Could I have the next slide, please? So this just moves on to 1-year survival rate, which I think I mentioned before. It is improving. We've moved from where we were below England, England being the blue line, orange being the Cheshire Merseyside line, to above. And Southport and Formby have got the highest 1-year cancer survival rate at 76.8%, with Halton being the lowest at 73.4%. And we haven't shown that data split out for CCGs on this slide. Could I have the next slide, please? There is a hand up. I don't know, am I allowed to answer questions while we're presenting? I'm not sure.
I think for the purposes of time, we're leaving them until the very end, Jenny. So if people can use the chat function, thank you.
Thanks. Okie doke. So what we've done here is we've just split out 1-year survival by the cancer types. And this is what I was touching on before, with the lung cancer being so much less for survival, the orange line, compared to breast cancer being the highest. We've also shown colorectal and all cancers for comparison. Next slide, please. I am conscious I'm going through quite a lot of data very rapidly. Leading on from the 1-year survival, the next one we obviously look at is 5-year survival. Again, there's an ambition for an increase in the number of people reaching that by 2028. Our survival is similar to England, and I think at the current trajectory we may reach 65%, but it doesn't look likely we will actually meet 70%. But then again, maybe England won't either. It's not, as I say, it's not just a Cheshire and Merseyside issue with finding challenges reaching some of these ambitions, and that's why they're ambitions, because it's what we'd like to achieve, and then if we work towards it, we still achieve an improvement. Next slide, please. Okay, so the last 4 slides, I think it is. I just wanted to put in context a little bit the range of data for PCNs because of the focus of this webinar. So the data on these following slides is taken from the Public Health England fingertips tool, and it looks at some of the indicators from there. So the first one is the QOF registered patients by practice. And you can see that there is variation. We've got 5.101% of patients in healthier West Wirral, down to 1.4. Now, we wouldn't expect PCNs to have the same level of patients because it will depend on the type of patients that are registered with them. For example, in older populations, you probably expect there to be a higher proportion with cancer. And then in younger populations with lots of students, maybe you would expect to have much lower. So this is more just to show that there is a range rather than to cancers. So it's something that's looked at as part of getting the tips. And it does exclude melanotic cancers. Next slide, please. That was prevalence, and then this is incidence within a year. So for this one, it's in terms of per 100,000 population, and we're ranging from 915 in, again, it's Healthy of West Wirral, they seem to be the top for most of these slides, down to central Liverpool again at 315. Yeah, so I've included the England average in as the black dotted line and an orange dotted line in this case for Cheshire and Merseyside. This data is from 2018-19. The previous slide was 19-20. It does just depend when that data is published as to what we have available. So it's always worth looking on the fingertip site if you were curious about what is currently out there. Next slide, please. Next, this is, I suppose, one that's relevant to yourselves is the rate of referrals from GP practices into cancer services. So we're looking at 5,600 per 100,000 population in IGPC. I wasn't sure what that stood for. To 2,485 per 100,000 in central Liverpool. This is all records with a referral priority of 3 for 2-week wait, and it excludes patients referred for non-cancer breast symptoms. Next slide, please. And finally, I've just included conversion rates. So of those referrals, how many are actually diagnosed with a cancer at the end of the process? And for that, we're looking at between 8.9% and 3.5%. And what we look at for the Cheshire Merseyside average is it's around about 6% that we have as a conversion rate within Cheshire Merseyside as a whole. So again, it will relate to the types of people within practices, whether these are worried well, whether these are going to be people with more complex needs, maybe with more comorbidities. So it's not a commentary on whether good or bad, it is purely just to demonstrate that there is variation within the patch. And maybe people are facing slightly different situations in their own local PCNs to some of the others. Next slide, please. I'll just include a link to the fingertips tool that I've used for those last few slides. We can provide data sources for the other data within the pack if needed. They mostly come from Cancer Stats and NDRS. And I think that's it for me. I think that's the end of my slides. So I believe Debbie is next on the agenda with primary care and CMCA interface.
Thanks, Jenny. Hi everyone, I'm Debbie Harvey. I work as a GP in South Sefton and I'm the primary care lead at the Alliance. Next slide, please. So just have a couple of slides and we thought it was important for colleagues working in primary care to hopefully be assured and reassured that there's quite a significant primary care presence at the Alliance. So this is a slide just to summarise some of the aspects of the Alliance that I and other GPs are involved with. So just starting at the top, I'm a member of the senior management team. I'm also on the Cancer Alliance board along with a fellow GP, Sinead Clark, who works in East Cheshire. I'm also funded by Cancer Research UK, which is a great positive part of my job because it means that I can link in with other national GP leads. I also chair the GP Cancer Quality Group, and that group has membership from CCGs and their cancer leads across Cheshire Merseyside. We have some brilliant cancer leads across our footprint who are also very much involved in a lot of the work at the Alliance and representing primary care. I'm also the clinical lead for the Prevention, Early Detection and Personalised Care programme, and also linking in with something which Lucy is going to tell you about shortly, and that's the Cancer Academy. So that's our newbie on the block, which is very exciting. There are lots of other programmes of work that I link in with as well. So with the pieces of work that Chris described earlier, we try and ensure that there's primary care representation across all of those. Next slide. So the other part of our offer, if you like, is to ensure that we have resources and support for primary care. And this is particularly relevant for the DES and the COF QI. So just starting in the centre, much as today, which is more of an informative rather than educational webinar, we try and have educational webinars, and if people have ideas as to what they would like us to do in those, please let us know. Just looking at the top right, the online class picture there, that's making reference to the Cancer Academy, which I mentioned before, and Lucy's going to describe that in more detail. We hope that we're a source and a point of contact. So myself and Louise have emails, which hopefully you have, so that you can email us with queries. And I have also spoken to colleagues on the phone about queries. That's not a problem. That's what we're here for. We have also produced a bulletin, which we try and issue on a monthly basis. Hopefully you have received that bulletin. We do have a bit of an issue in a contact list with PCNs because NHSE won't share the list of PCNs because of GDPR. So if you or colleagues have not received the bulletin, or you feel we need to know about you, please let us know and we'll pop you on our list of contacts. And at the top left-hand corner, we're just publicising our website, so Paul is going to describe that to you later, but the website has a big section for primary care, and what we have tried to do there is to create supportive tools for the DES and COF QI. And again, if you feel that that's not quite right and there's other stuff that you require, please let us know and we'll do our best to develop new areas on the website and indeed on the Cancer Academy. And next slide. So I think we're going to be handing over now to Lucy. So the next part of this afternoon is about spotlighting various programmes of work at the Alliance. They're very brief and they're overarching summaries, but will hopefully just give you a flavour of some of the work that's going on. So I'll hand over to Lucy.
Thank you, Debbie. Just check everyone can hear me.
Yes, we can.
Fab. Okay, lovely. Hi, everyone. Thank you for inviting me today to speak to you all. My name's Lucy Erwin, for those of you that don't know me, and I'm Project Manager for the Cancer Academy here at the Alliance. And I just wanted to give you a short overview of what the Cancer Academy project is all about. So this is going to be an online cancer education and knowledge resource that's hosted by the Alliance. And its overall aim is to drive improvements in cancer prevention, early diagnosis and care through high quality education for health and care professionals. Oh, you've already on the next slide. Sorry, I've got two screens, so I'm trying to present with my screen to the side. Okay, so I'm very excited to show you a sneak peek of our first draft of our homepage today. So you're the first people to see this. And phase 1 of the project is planned to launch in December. And in this initial phase, we'll be concentrating on resources for primary care, as well as education and training for our cancer support workers. And some of the modules will be available for the likes of our social prescribers and interest for link workers and other roles similar to that. So we're working really closely at the moment with our design team, our software designers, and we are trying to create a really professional, high quality site that's most importantly user-friendly. We're keeping that sort of at the top of our list of priorities. We need to make sure this is user-friendly for the workforce to use. So education and training will be offered as a blended learning package with both self-directed learning and virtual classrooms, as well as webinars. So how are you going to access this? I hear you ask me. The healthcare professionals that are accessing this will be able to register on the homepage, and then they will have full access to the content that we pop on there. They'll have their own user dashboard, which will keep a record of what they've attended. And this will be really useful for us to inform us of what people are actually attending, so that we can look at that in more detail. We also have a plan to have a section which is purely for externally recommended resources. We know there's a lot of really good stuff out there, and we definitely don't want to be duplicating what's already been created. So we will have a nice description of what's out there with a link to other sites such as the Macmillan Professional Learner site, CR UK, and Gateway C as some examples of that. So it'll almost be like a directory of where to go, depending on what an individual's looking for in their development and training. We're currently working with our cancer support workers to create a useful induction information and course content around what we're actually going to provide on the site ready for our launch. So there's a lot of work going on with the experts, the cancer support workers. And I'm also working in collaboration with Sharon Rowe, who is our workforce lead at the Alliance. And she is in turn working with Health Education England to develop a standardised education and training programme for non-clinical staff. And Sharon is actually online today, but she's having some terrible issues with her tech. So if there are any questions later on, she is happy to answer them. But I'm also going to pop my email address in the chat box. So following on from the webinar, if anyone wants to get in touch with me or has any questions at all, please feel free to get in touch. And that's me. Thank you very much. We're on to Ellie now, I think.
Thanks, Lucy.
It's okay.
Hi, everyone. Could you go to the next slide, please? Thank you. My name is Ellie, and I am the Macmillan Quality Improvement Officer at the Cheshire Merseyside Cancer Alliance. My colleague Jo and I joined the Alliance earlier this year to form the Health Inequalities and Patient Experience Programme, which is jointly funded by Macmillan. Whilst inequality has existed within all aspects of our health, including cancer, for many years, COVID-19 has highlighted just how unfair and avoidable health inequalities are and the devastating impact they can have. The Health Inequalities and Patient Experience Programme was introduced to better engage within all stages of transformation and to support the understanding and use of health inequalities and patient experience insights across our programmes and projects. In Cheshire and Merseyside, just under a quarter of our neighbourhoods are in the 10% most deprived in England. 500,000 people are digitally excluded. 2.3% of people do not speak English as their main language, and around 2% of people have a learning disability. People from these groups are more likely to experience inequalities in the prevention, detection and treatment of cancer. So as part of the first phase of our programme, one of our first priorities was to increase awareness around the barriers people may face when accessing health services. We created a top tips page which provides 8 quick prompts for GPs to consider when engaging with patients. These focus on groups who are known to experience barriers such as people who have an existing disability or health condition, or who are a carer. We also created a toolkit of resources and support for both professionals and patients, which focus on creating an inclusive environment. To support professionals in addressing the barriers people may face, we developed a checklist, which provides practical advice and support in areas such as language, access and involvement. We have also delivered training to the Macmillan Partnership Managers and are currently devising training for professionals in the form of a workshop. As part of the second phase of the programme, we are in the process of establishing a health inequalities engagement framework and designing community projects to support the Alliance in engaging with people who have lived experience. This will improve patient experience by ensuring that the views of the local community are listened to and projects are tailored to meet a diverse range of needs. The resources are all available on our website, but if you have any questions or need specific advice, please do contact us. I'll now pass on to Mairead, who's going to talk about community engagement.
Lovely, thank you for that, Ellie. Perfect. So hello everybody, my name's Mairead Hayman. I am a project manager for the Cancer Alliance and I joined the Alliance a few months ago. So I'm going to give you a little overview of what I've been up to since I've been in post and hopefully what the rest of my term with the Alliance is going to look like in relation to the community engagement work. So for those of you that haven't been part of the working group and steering group, and thanks to those that have been, we've been doing some extensive work over the last couple of months, understanding more about the needs in relation to how the Alliance engages with the community. Obviously, following the pandemic, there's a huge amount of work that needs to take place and a huge amount of scoping has been happening. We have set our aims into 3 areas for the first year, and that's going to run up until March of next year, where we will be scoping further to understand what this looks like. But the 3 areas that we're focusing our attentions on for community engagement in the short term of year 1 is Knowsley, Holton and Warrington. And hopefully the people that sit within those groups, that you have been contacted by us, and if not, it would be wonderful to hear from you if you have some issues and outcomes and priorities that you'd like to discuss with us. So we have a pot of around £300,000, which we are dividing into 3 into £100,000 pots each, and we'd like to see some improvement in relation to early diagnosis and awareness of signs and symptoms, working alongside some screening programmes as well to understand the recovery from COVID. In our first year, we would hope to achieve this in an understanding of engagement with community groups, and within our working group settings, we have been engaging with CVS over some voluntary work groups that we could engage the money with to ensure that this money is going to the root of the communities. We've chosen some tumour groups of which we would like to concentrate on, although we completely appreciate that it's not a lot of time or a huge amount of money to have a huge impact on these tumour groups. And our main focus is to ensure that the access to the community and how that integrated system happens between the community and their GP practice with yourselves in the PCNs is a clear pathway for support. We're hopeful that this isn't going to an attempt to create more work for primary care. In effect, the hope is that by using educational tools and support within community groups, that people will be able to identify early signs and symptoms, or at least know how to identify them themselves under an educational process, whereby they can share that support internally with their friends and family, as opposed to potentially presenting unnecessarily. There's a huge amount of work going on in relation to the community work. It's really exciting, and we are moving forward with it at quite a pace now that we've done all of the scoping and data collection. But yeah, it's a fantastic opportunity for us within the Alliance to work with the community groups closely. And I hope, as previously said, that if you do sit in the Holton, Knowsley or Warrington group, that you've heard about our plans over the next coming months. And if not, it would be wonderful to hear from you. So that was me. So sorry, I haven't got who I'm passing on to now. Sorry, it's over to Steve now.
There we go. Thanks, Marie. Hi, everyone. I'm Steve Jones, Senior Project Manager with the Cancer Alliance. I'm just going to give a very quick overview on some of the prevention work that we've been developing. So next slide, please. Thank you. So obviously community engagement is a part of that and a big part of that, but the other 2 that I wanted to focus on were obesity and tobacco control. So obesity, as many of you will be aware, is the 2nd biggest modifiable risk factor for cancer, but in the grand scheme of things is a relatively small slice of cancer. And overall, the agenda for obesity, cancer is a small slice of that. So we've prioritised the work accordingly, but we think there's a really important role that the Cancer Alliance can play in helping address obesity as part of a system. So we've pulled together a working group and have engaged some key stakeholders across the system, people already working in various aspects and elements of obesity. And what we've decided to do is to develop an approach whereby we identify an organisation, a third sector organisation external to the NHS, to host a role that will act in some of the ways in which alliances are set up to operate. So that being infrastructure and providing some of the facilitation to bring the system together. So it's quite vague at the minute, and it will be taking the Cancer Alliance into some odd areas for us, because a lot of the drivers of obesity and the real social determinants that drive obesity can go quite far away from areas in which you would normally expect a Cancer Alliance to operate. So some of the obvious ones will be around healthy diet and exercise and those kinds of things, but it's also really important, based on some of the work that we've discovered, that we take this whole systems approach. So that's things like town planning, it's private sector, it's accessibility to all of those wider drivers, So we're currently in the process of developing or exploring the process. We're hosted by the Clatterbridge, so we need to understand the process whereby we can identify this organisation that's going to host the role. We're working with key partners across the system to develop what the outputs and outcomes will look like for this. It is quite high level and it is very strategic currently, but what we're hoping is that this role and this and hopefully the organisation as well will pull together the system in ways that doesn't exist elsewhere. And it kind of reflects the way that the Alliance works. So the Alliance is a way of viewing the Alliance is the infrastructure for cancer across the entire system. And that doesn't exist for cardiovascular disease, which obesity would typically come under. So we want to try and provide some of that for obesity as a topic. So we're hoping to see action starting to happen by the end of the financial year. A lot of work has gone on to pull all of that together. Tobacco control is obviously a lot more typical for a cancer alliance to be involved with. So there are a number of pieces of work. So we've commissioned a Cheshire-wide smoking and pregnancy project that's going to be delivered by the local maternity services. They're in the process of recruitment to that now. And we are in the process of coordinating that with the local ICS plans. So some of you might be aware that a fairly significant amount of money has come into the system from NHS England through the ICS. Across the next 3 years, the 3 priority areas for the ICS are smoking and pregnancy, secondary care, in-house smoking cessation services, and mental health. So for year 1, they're prioritising the secondary care work. And that ties in nicely with the work that we've been doing supporting 2 cure projects in Liverpool and in Mid Cheshire, but also a lot of the core principles and the approaches that the NHS England are instructing the ICS to work along mean that we can connect our smoking and pregnancy project with that, so we're not working at odds and actually building on the work that the ICS are starting now. So there's a lot of really good work that we've been doing to connect the two. And lastly, it's important to know that we've appointed a few months ago now a clinical leader as a respiratory physician in Liverpool who headed up the cure programme to drive work through some of the existing pathways. So whilst the cure programme is rolling out across different trusts, what we also want to do is to work with the individual pathways and CQGs to explore where there can be improvements there. So there's lots going on with tobacco, and again, it's about a system-wide approach, working with partners across the system. I'm going to have to drop off now, but if there are any queries, I'm happy to pick them up and follow up with anybody afterwards, if that's helpful. Thank you.
Thanks, Steve. So I introduced myself earlier. I'm Senior Quality Improvement Manager at the Alliance, and as part of my remit, I'm leading on the implementation of the NHS Galleri trial, also known as Grail. So just to give you an overview of the trial and some of the processes within it. So the trial is a prospective randomised control trial to establish if screening with Galleri reduces incidence of late stage cancer when used in an asymptomatic population in combination with existing NHS cancer screening programmes. It's a collaboration between the Grail, NHS England and King's College London. And this trial does align with the NHS long-term plan ambition of 75% of cancers being diagnosed at stage 1 and 2 by 2028, as discussed earlier by Jenny. The trial's being rolled out across 8 cancer alliances, with Cheshire Merseyside and London being the first pilot areas. It's a 3-year trial with the aim to recruit 140,000 participants in year 1. And so that equates to approximately 20,000 participants for Cheshire Merseyside. The trial wants to recruit participants from diverse backgrounds to make sure that the trial outcomes are representative of the UK population. We had a national launch of the trial, which took place early September, which you might have seen on national and local press. And that launch took place in Runcorn, which was the first area in Cheshire Merseyside to go live. The actual Galleri test has been developed by Grail, and it's a promising new biomarker technology for early cancer detection, and it recognises methylation patterns in cell-free DNA, which is shared by dying cancer cells in the bloodstream. It's a simple blood test, and it can identify over 50 different cancer types. The test has a very low false positive rate and a high positive predictive value for cancer, and that was demonstrated in early clinical studies. And that means that if a positive blood test is shown, then that warrants early urgent investigation within 2 weeks to ascertain individual cancer status. In order to take part in the trial, participants must be aged 50 to 77 years old. They must be registered with a GP within our alliance and not have been diagnosed with cancer in the past 3 years or currently under diagnostic follow-up for cancer. Participation's by invite only, and participants will be invited via direct mail out, which is DigiTrials, and it's based on postcodes and eligibility for trial. Once invited, participants can book an appointment via the website or telephone booking line. There's also a website and helplines for people who've got questions before taking part as well. So participants will be asked to confirm eligibility. They'll be cancelled. They'll require consent will be required, and then they'll have to provide a blood sample and complete a questionnaire at each appointment. And then participants will be asked to return in years 2 and 3 for further samples. As I said earlier, this is a randomised controlled trial, so 50% of the participants will have their blood samples tested and 50% will be in the control arm. And only participants in the intervention arm that have a cancer signal detected result will be told of their results. And all participants are reminded to continue to attend their national screening appointments and obviously report any changes or signs and symptoms to the GP that might be indicative of cancer. The process for positive signals, so if a cancer signal is detected, this will specify cancer signal origin, and that will assist in subsequent necessary diagnostic investigation. The participant will be contacted via telephone by the clinical nurse, and clinical trials nurse, and they will be counselled as well. And currently the referrals are going into the RDS non-site specific service for trust to manage, but this may change depending on trusts' access to non-site specific services as the mobile moves across Cheshire and Merseyside. Regardless of the pathway, all the 2-week referrals will be sent via ERS, and all relevant diagnostic tests that would be normally undertaken via primary care prior to referral will be managed by the accepting trust. And participants' GPs will be informed at point of referral, but no action is required from them. So the locations across Cheshire and Merseyside, Runcorn have completed their round, as I said, they went first. It's the units currently in Warrington and will be till the end of November, before moving on in order of St Helens, then Widnes, then Liverpool West covering Liverpool and South Sefton, Liverpool East, which will be covering the Knowsley area, moving on to Southport, Chester, Wirral, Mid Cheshire, and lastly East Cheshire. So that's just an overview of the trial and where that will be positioned over the next 10 months. So I'm now going to hand you over to Sue Fox, who's going to talk about the 2-week referral template project.
Thanks, Louise. Thank you. Thank you, everybody. My name is Sue Fox. I'm a Senior Project Support Officer for Cancer Alliance. And my presentation will be around the work that's commenced for the development of the 2-week wait electronic referral templates. Next slide, please, Nicola. Thank you. I'll be working closely on the project with Dr. Kathy Hubbard, who's on the call today. She's kindly agreed to be the clinical lead for the project. You may be aware she's a GP working in Liverpool. She's got a keen interest in supporting this project and is quite techie savvy as well. Louise, who's just presented earlier, is the Cancer Alliance's Senior Quality Improvement Manager, and she's also involved in the project as well. So my presentation is just going to very quickly look at the 4 arms of the project, starting with strategic importance. As you've heard before, and I do feel like I'm repeating a little, but the NHS long-term plan includes the requirement for Cancer Alliance to work with PCNs to support the implementation of cancer early diagnosis DES and the quality improvement module in the CLOF. The NHS plan, as you've heard, sets out that by 2028, the proportion of cancers diagnosed at 1 and 2 will rise to 75% of patients. So from a regional level, this work will also contribute to the Cancer Alliance's Rapid Diagnostic Centre delivery plan. And the principle in that is that referral forms will have a defined minimum data set, and that will inform triage process, and that those forms will be tailored to each tumour site as per the guidance and as per best practice. So the aims of the project are threefold: to improve the quality of suspected cancer referrals, to assist GPs in recognising early signs and symptoms of cancer, and finally, to optimise suspected cancer referrals. To achieve these aims, moving on to the project, and for each major tumour site, what we're going to do is work with the RDS project team, and Gemma's following me, who will establish the minimum referral criteria and gain approval by the clinical quality group. We will then look to gain approval by the GP clinical quality group and any other relevant clinical stakeholder, for instance, endoscopy network groups. We'll produce referral forms for each tumour site that incorporate the approved criteria, but ultimately we'll develop a suite of electronic 2-week templates for upload within the primary care systems. So once we've done this, we'll develop plans for how we implement and upload the templates within GP surgeries, looking at any particular local pathways, such as whether there's direct access to diagnostics. We'll produce a suite of educational tools for GPs to support the early signs and symptoms recognition of cancer, and for optimising those referrals. And finally, we'll promote and embed the use of the electronic templates within the GP practices. So next steps for the project will be very much aligned to the RDS delivery plans. Work will be going on in parallel, however, so that when the agreement and approval of the minimum referral criteria has happened, in the meantime, we can confirm what resource is required and cost of particularly any IT support, so that we can develop the templates, we can implement them successfully, but also that we can provide the ongoing support to users. Those conversations are already at an early stage, but they are underway. In fact, Kathy and I have just come off a meeting to look at some potential templates. So then we're going to look at a pilot to put in an approved template into a small area, understand any challenges or any further work we can do. Again, Dr. Hubbard has agreed or offered that if possible, she will trial this in one of her areas if at all possible. Key to the project will be the promotion and communication of the templates, educating them, user support going forward, but we'll work with everybody that's necessary in each area to ensure that they are and that they feel fully involved. It's going to be quite a technical project, but it should be hopefully very successful, and we'll make sure we keep everybody fully informed. And that's me. Thank you for your time. I'll hand over to Gemma.
Hi, thank you. My name is Gemma Hockenhall and I work as part of the Cancer Alliance's Rapid Diagnostic Services team. Next slide, please. Thank you. So this has been said many times over today around the national ambition that's been set out in the NHS long-term plan. Rapid diagnostic services are very much a part of how we respond to that ambition, and the idea of rapid diagnostic services or pathways is that we look to support earlier and faster diagnosis, more efficient diagnostic pathways, better personalised and diagnostic experience for patients, try to reduce variation within services, and to improve the offer to staff in terms of developing their opportunities and chances to work in innovative ways within their services, and look at opportunities to develop new ways of working within cancer services. Next slide, please. So what is a rapid diagnostic service? This has been taken from the national specification, which is made up of 7 key RDS components. The first being the early identification of patients where cancer is possible. The second being timely referral, looking at standardised referral criteria and filter function tests that can be done prior to referral into secondary care, so very much involving primary care networks. The broad assessment of symptoms, so the effective triage of referrals when they come in so that patients can get to the most appropriate test as quickly as possible. Looking at how we implement coordinated testing, so how can we bring tests together, perhaps introduce one-stop shop testing so that patients visit the hospital as fewer times as possible during their pathway. Looking at the timely diagnosis of patients, getting them to MDT as quickly as possible so that decisions on their treatment or exclusion of cancer can be done as quickly as possible. And the appropriate onward referral of patients to the right service. Should cancer be excluded, this is an important part. We know at the moment that often when cancer is ruled out, the patient can still be left with symptoms unresolved, which means that they swing back into primary care, and then that revolving door happens. They need to be referred back in for further diagnostics. So how can RDSs look at those pathways for patients who've been excluded of cancer but maybe need some further investigation? And that's all underpinned by the coordination of that care and the support that the patient receives whilst they're being investigated, and having a single point of contact and to know who or which service they can speak to throughout that diagnostic experience or pathway. You will notice it says 7 principles, and in Cheshire Merseyside we made the decision to introduce an 8th principle to our RDS work, and that's to include looking at clinical trials and research opportunities that are available for our patients whilst they're going through these pathways. Next slide, please. This is, oh sorry, could you click on? I didn't realise these came up one at a time. So in terms of how we, sorry, just go back one. In terms of how we look at the design or our approach to rapid diagnostic services, it is our responsibility to ensure that we are the funding that we receive for rapid diagnostic services, we provide that proportionately across the system in a transparent way. It gives us the opportunity, as I mentioned earlier, to deliver a standardised approach to our clinical services. And it also gives us an opportunity to perhaps touch on new ways of working and new models within clinical teams. If you just click, not the next slide, but just the next couple of bullets.
Sorry, Gemma, 1 second. It doesn't seem to be.
That's my fault. Sorry. Thank you.
Yeah,
thank you. We also need to ensure that we have a wide engagement and align our work with other teams and other programmes, and all of the people who've presented up to now on the work that they are doing, all of that work can be incorporated in our approach to rapid diagnostic services and meeting those principles of a rapid diagnostic service. We have an opportunity to address some of the common challenges, and in particular we want to be looking at how we can address health inequalities and getting better access into some of these pathways for certain patients. Part of what we do is very much to ensure evaluation and sustainability are built into all of the planning that we have. We are often able to give pump priming to trusts to look at new ways of working, test new models, recruit new staff members, but we really need to be supporting the trust with evaluation and how they sustain those roles or those new ways of working long term. And obviously, as things and the climate changes, we need to be flexible and we need to adapt to make sure we're meeting the needs of the patients. We also have an opportunity to direct other work as well. So, for example, the introduction of community diagnostic centres. How can we perhaps influence the cancer agenda through them, and some of our rapid diagnostic service pathways through CDHs as well. Next slide, please. So the current position for the RDS team, if you just click again, but not to the next slide, they keep coming up. This just gives you an idea of some of the tumour sites and the pathways that we are focusing on at the moment. The one in yellow you will see is vague symptoms, and you may be familiar with that. That is now referred to as a non-site specific RDS. So that is a pathway for patients who come into primary care with vague symptoms that don't fit a normal 2-week wait pathway. And you have the opportunity to refer patients in via that vague symptoms pathway or non-site specific service now. We also have a lot of cross-cutting work with the endoscopy, pathology and imaging networks, and we work very closely with those diagnostic networks to look at the challenges, obviously, that are being faced around diagnostic capacity and how we can overcome them within rapid diagnostic services also. So that's just a flavour of where we're up to, but for the team, the implementation of the programme across all tumour sites by 2024 means that we're having to work with around 90 cancer teams over the next few years. So it's a big undertaking, but one that we are moving really well with. So that's everything, and I will pass over now to the next speaker.
Hi everybody, thanks very much for the invite to join you today. My name's Lindsay Booth. As you can see, I'm a senior project manager within Cheshire Merseyside Cancer Alliance. I've been with the Alliance for about 2 years now, and recently became the lead for personalised care. I'm going to provide an oversight of our programme today, which aims to improve patient experience and cancer outcomes in Cheshire and Merseyside through providing individualised personalised care and support to cancer patients. So the next slide, please, Nick. So what is personalised care? What it's about really is how the Alliance can support working towards giving people choice and control over the way their care is planned and delivered based on what matters to them and their individual strengths and needs. We want to empower people to manage their care and the impact of their cancer and help them to receive digital and community-based support, ensuring that they have access to the right help and expertise at the right time. Personalised care is fundamental to delivering better quality integrated care that's meaningful to the individual, and it's therefore underpinning pretty much everything that we do here in the Alliance. Can the next slide, please, Nick? So a bit of background, as we've all talked today about the long-term plan for cancer. In regard to personalised care and the projects that we're working on, it's stated that by 2021, where appropriate, every person diagnosed with cancer will have access to personalised care, including a needs assessment, care plan, health and wellbeing information and support, and it'll provide new patient-level data that we can use to track delivery and services. It also went on to state that after treatment, the person has moved to a follow-up pathway that suits their needs, and they can get rapid access back to clinical support if they're worried about their cancer symptoms. Cheshire and Merseyside in the last few years have delivered against the target to ensure all appropriate trusts have PSFU pathways in place for breast, colorectal and prostate patients by March 2021. And that includes the delivery of HNAs, care planning and providing health and wellbeing support embedded within those pathways. As a result of this work to date, we estimate that by the end of this financial year, over 27,500 outpatient appointments will have been released by patients moving to remote PSFU. The COVID pandemic actually had a positive impact on the personalised care agenda, accelerating and expanding initiatives, particularly PSFU models, which enabled organisations to keep regular contact with patients but reduce attendances and provide prompt advice and information to patients and encourage patients that might not previously to opt for self-management services through PSFU. The opportunities presented by developing personalised care models were emphasised in the 2021-22 priorities and operational planning guidance, which stated that delivering the NHS comprehensive model for personalised care and thereby giving people more control over their own health will underpin systems' efforts to recover services. So the pandemic provided us as an alliance with further impetus to transform the delivery and design of services across the systems, reduce variation in access and outcomes, and accelerate progress on digitally enabled care. And the next slide, please. So, reflecting on this, our personalised care programme aims to support the implementation of stratified follow-up for all appropriate people with cancer at the end of their treatment, promote personalised care for all people with cancer, explore the use of stratified follow-up for those with long-term conditions where there's a high risk of cancer, optimise patients who are suspected to have or have been diagnosed with cancer to improve their health and well-being, and to understand and start to tackle improvements in patient experience, as has been previously described by Ellie in an earlier overview. We're also looking to explore how technology can be used to support the delivery of personalised care. So, next slide, please. So, as a personalised care team, there's 8 of us. We're leading on multiple projects across a range of trusts, CCGs, providers, working with the third sector. And because the time is limited, I can't speak about each individual project in detail. But an overview, the main ones is looking to ensure that an additional PSFU pathway is implemented at all trusts. Some have already done this, and we're working with the others to support them to do that. And we're also developing a suite of clinically approved protocols that trusts can access. Those include stratified follow-up pathways and protocols for haematology, gynae patients, lung, advanced bowel, and also head and neck patients. We're also working with trusts to expand PSFU approach for those with long-term conditions, as I say. So we're looking at pathways and protocols there for skin, liver, and also pre-prostate patients. Across all trusts, we're looking to support the embedding of personalised care interventions. The 4 main ones to be embedded are, as we've said, end of treatment summaries. We're looking at HNAs, personalised care planning, health and wellbeing information and support, and also looking to improve the uptake of the quality of life survey. The projects that we have in place to support this will support just in measuring how embedded personalised care interventions are within their business as usual, within their service, identify any gaps and explore how implementation within trust can be improved, and also look at the quality of those interventions that are being delivered for patients. We're involved in extending prehab services for Wirral and Liverpool patients, and also enabling Mid and East Cheshire patients to access Greater Manchester's Prehab for Cancer service. We're funding an independent evaluation of the different models that are being trialled to look at cost effectiveness and patient outcomes, and then to produce an overall evaluation on and recommend how services could be expanded, delivered, improved and made available to as many patients as possible across Cheshire and Merseyside. We're working to improve personalised care in the community with projects in Mid Cheshire and scoping across Cheshire and Merseyside. And the aim there is to increase access to personalised care planning in community settings for people living with and beyond cancer, and also to bridge the gap between support offered following treatment in the acute setting sector and that's available in the community following discharge. Underpinning all of this, as personalised care does, but to support that is looking at digital developments. So it's identifying and bringing together the various digital requirements to deliver personalised care for patients and staff. We're trying to make sure that patients don't have to tell the same story numerous times in numerous places, and having those stories recorded in numerous different places that not everybody can access. We're working collaboratively with Macmillan to develop a roadmap for HNA development across the region. And we're looking at how we can optimise processes to ensure, as I say, eHNAs are completed at the right time and place. So that is very much a whistle-stop tour of the projects that are underway through the Alliance at the moment within the personalised care programme. And I would just encourage yourselves as PCNs and stakeholders within the community to please get in touch. Let us know how we can support, and let us know what services you do have in the local area and what you'd like to see developed, and how we can help to coordinate and link those services together. Thank you. Following on from myself is now Paul Ogden, who's our communications manager.
Hello everyone, I'm Paul Ogden, communications manager at the Clatterbridge Cancer Centre. For 3 days of my week, I'm dedicated to working with the Cancer Alliance on communications. This is a new role which began in March, and I'll give you a brief overview of how communications now works at the Alliance, and then focus on our website and how it can support primary care colleagues. Next slide, please. The aim of communications at the Alliance is to improve the visibility of the organisation and its work with professionals, patients, stakeholder organisations and the public. We also want to inform, to be a repository for information and reflect the positive things that are happening right across Cheshire and Merseyside in relation to cancer, despite the real and obvious challenges we all face. We also link with regional and national NHS communications teams and align ourselves to current NHS messaging. Our communications to health professionals covers primary, secondary, specialist and community care. And the main vehicles for our communications are social media, campaigns and our website. Next slide, please. We spread our messages and information via the Alliance's social media channels. Historically, that's been Twitter, mainly to target professionals and stakeholders. And we've recently revived our LinkedIn profile to inform professionals. And we've increased the number of videos on our YouTube channel for the public and also professionals. And last week we launched a Facebook page for the Alliance, which will be mainly used for patients and the public. So please follow our channels and share our content with your networks if you're able to do that. Next slide, please. We also publicise and initiate campaigns, including targeted lung health checks and the NHS Gallery trial, which we've heard about today, and awareness campaigns, including a recently launched bowel cancer screening promotion, which we created for South Asian communities in specific areas of Liverpool. Next slide, please. The Alliance relaunched its website in May, and the site is designed to be used by professionals, but also by patients and the general public. So it needs to be accessible and understandable, but also contain in-depth information which healthcare colleagues can find useful in their work. The website's growing organically in the amount and breadth of content it has, and we've recently added 2 new sections to the main menu: patient experience and health inequalities, and information for the public. Next slide, please. The part of the website specifically dedicated to primary care is in the resources section and is curated by Debbie and Murray. It's designed for GPs and primary care colleagues as a reference point for many aspects of cancer which they may encounter, from how to make a good referral to how to promote screening programs within their practice and PCN, to tumour specific advice and information on the QOF and DES in relation to cancer. This section also houses the regular GP bulletins, which Debbie mentioned. They're sent out by email. They've been running for about 9 months and are short newsletters with information about the Alliance of interest to primary care. So please sign up for those if you wish. Next slide, please. But there are other areas of the website that GPs and PCNs might be interested in. We have resources for professionals in addressing health inequalities, which Ellie talked about earlier. There's also a section of news involving issues relating to cancer from across Cheshire and Merseyside, from CCGs, NHS trusts and charities. We now have a section of in-depth blogs on particular programmes which the Alliance is involved with, designed to be of interest to professionals, but also for the public. The website content is growing, but we want it to be relevant and to be concise, so that the site's still simple to use for professionals who may need to find information quickly. But we really do want your feedback on that information. Tell us what you'd like to see more of, what we could add to support you in your work. and also how you think we could improve our communications generally for you, your patients, and your colleagues. I'll put a link to the Alliance website in the chat for people. Thanks very much. And I think it's now time for questions.
Thank you, Paul. And thanks to all of our speakers. We hope this session's been really informative for everyone and provided you with further insight into the Cancer Alliance, our brilliant team here, and the many programmes that we're currently involved with. So I'm conscious of people's times. It's coming up to 3 o'clock, and obviously they need to get away and finish at 3. So rather than move on to any Q&A now, if people could put their any questions you've got in the chat box, and we will answer these offline and send out responses with presentations. Or alternatively, if people don't want to put questions in the chat box, if we just move on a couple of slides. Nicola, please. Myself and Debbie's email address is in the slide pack, and we'll also put it in the chat box as well. So please feel free to email us separately. So just a couple of next steps following the webinar today. We will be sharing the slides, as I've said, and the recording, along with any useful links to support primary care. We'll continue with our monthly bulletins to primary care. And if you'd like to be added to the distribution list, please drop us your email. And we will continue with these webinars. We feel that they're really informative and really useful, and we hope you think the same as well. So, you know, we would welcome your input into the design of these webinars, the contents, etc. So again, feel free to drop us a line with any ideas that you've got. You know, we want to tailor these to make sure that they're fit for the local need and purpose, really. So yeah, so this is your resource. Please use it to the best that we can make it, and feedback to us on any topics or content you'd like to see covered. So just say thank you again to all of our speakers and to yourselves for joining us today, and we hope to see you again soon. Thank you.